This session will be Dr. N. Kumarasamy from Chennai, whom we have heard since morning also. Impact of WHO 2016 ART guidelines. Dr. Kumarasamy.
Good afternoon. Thanks again for the opportunity to do this presentation. So this particular session is on comorbidities. So I might be focusing more on the impact towards the prevention of comorbidities. What will be this impact? And also for some of you who heard my talk this morning, first part of my talk will be a little repetition, but I may go a little faster. This session was sponsored by Gilead Science, so what I'm talking is not being coerced by them. It's been purely based on science and from data and from guidelines. I'm sure everyone here knows that this you have seen might be like today the 30th time, and I had also shown twice earlier. So what is this WHO 2016 guidelines is today's treat all. And irrespective of the CD4, irrespective of the symptom, irrespective of the pregnancy status or anything, someone who's HIV positive, put them on treatment. So, and again, coming to the impact, so I'm going to use the same slides, but I'll be talking different stuff. So the HPTN-052 study, which again I said this morning, is the one which made all those revolution. So 5 years back, our group showed in the interim analysis, there is 96% reduction in HIV transmission, if you start treatment early, mainly the sexual transmission. The study was continued even after 2011, and we put everyone who were on delayed on treatment to assess the durability of HIV transmission. What we found is we are able to see the sustained more than 90% reduction in HIV transmission in those who are on antiretroviral treatment. This is the first impact when you implement this and the new WHO 2016 guideline. You'll continuously see prevention of HIV transmission, and that will be durable. But that will be durable only if, again, we had seen 8 linked transmissions in this HPTN-052. Again, if you looked into this the data, which I showed this morning, but I may walk you through a little more deeper into that. The 4 infection occurred either before or soon after starting treatment. That means don't wait. You're not going to see any impact. Test and put them on ART, make sure that they have been suppressed virus. And also 4 infection happened when these patients failed ART. So that means don't even give time for the virus to replicate when they're failing. Do viral load and switch them sooner. If you're not doing that, you're not going to see the impact of the prevention of sexual transmission of HIV following this ART. So today, the WHO 2016 guidelines strongly recommend put everyone on treatment, and where you'll see an enormous benefit of preventing sexual transmission of HIV. Again, I didn't have the slide since earlier session was very interesting where we talked about polypharmacy and we talked about reservoirs. One thing I like to show you, this morning I showed a slide, and also we had some partial evidence which will be presented at CROI if it is accepted, which I showed a slide on that. Again, starting treatment early will also reduce the reservoir size and reduce immune activation, which will also help future cure strategies. Again, I didn't have the slide to show, and we just submitted this paper for CROI. Next, going to the impact of new WHO 2016 guidelines is, the START study, the evidence. Again, this is a session on comorbidities. So what's seen in the START study is patients who are on immediate term, starting treatment at a higher CD4 more than 500, there is dramatic reduction of various comorbidities, both serious AIDS events and non-AIDS, which I showed this morning. So 14 in the immediate term and 50 in the deferred arm. And again, if you look into the non-AIDS complication, 29 versus 47. This very clearly shows that a huge impact on implementing 2016 guidelines on patients who are starting treatment early. And very importantly, again I said this morning, tuberculosis will be prevented, especially in a country like India, where you'll have a huge impact by implementing the recent 2016 guidelines. Please don't delay, do it. And also in sub-Saharan Africa, I've just seen dramatic reduction of Kaposi sarcoma in patients who are starting treatment early. And also, in the non-AIDS complications, especially the malignancies and cardiovascular and kidney disease, were able to be prevented by starting treatment early. There is a huge impact. There is no doubt on that. We have got enough evidence, and following this, the WHO 2016 guideline, start treatment early. And also, one thing we heard a lot about the previous session on drug-drug interactions and polypharmacy. Don't make your patients to develop all these opportunistic infections by delaying. But if you do that, then you'll end up in treating all these infections and putting on ART, where you'll have more and more drug-drug interactions. So if you put everyone on treatment at a higher CD4, before they start developing, then we may not have Jaideep Gokte's talk in the next ASICON, where we may not have that amount of drug-drug interactions. We waited up to patients to develop all those OIs, and now, patients have much drug-drug interactions. Start treatment early, where we'll have much more benefit to our patients, where again, with single FTCs, they will do very well. So the major impact today by implementing this WHO 2016 guideline is not only in this public health benefit, but also enormous on individual benefit by preventing various comorbidities. The next thing, which I didn't show this morning, is this might be like new to you. So we have now 2013 guidelines where we are using efavirenz 600 along with tenofovir 3DC or FTC as a fixed dose combination to initiate on treatment. So what had happened in the last 3 years is, this is a large retrospective survey, review of 4 NIH-funded ACTG clinical trials. Out of those, one was done in research limited setting in India, including Chennai and Pune, called ACTG 5175, and also 3 other studies. Data was being used for this retrospective analysis. So what this investigator did is, they looked into the data of patients who have been put on efavirenz-containing therapy, which was compared with other regimens. What's been found in that is, participants who are on efavirenz-containing therapy, they had 2.5-fold higher risk of attempted or completed suicide among those who are assigned to efavirenz. Today, we are talking about treatment for everybody. Even at 1,200 CD4, they're perfectly fine. When you put on efavirenz 600 milligram, we don't want our patients to develop this major comorbidity of attempting a suicide, and their near ones and come and report to you that you gave this drug, they committed the suicide. Now, this is just presented a couple of months back in Durban at the World AIDS Congress. So this is a sub-study conducted on the START study, which I said about, which recommended treatment for everybody. So their analysis was done on those patients who have been participating in the START study. So what's been found is, out of those 4,685 patients, 270 individuals had reported some sort of a prior psychiatric diagnosis. It could be depression or anything. So what's been found in that is, patients who have got history of psychiatric disturbance, they have higher reported evidence of efavirenz-related side effect, particularly on CNS, including suicidal behavior. So it's not just one retrospective study. Even in this prospectively conducted START trial in sub-analysis, shown that efavirenz 600 may not be a right drug when you put patients on higher on treatment. And one step going ahead, now today we all know that baseline resistance is moving from region to region, from 2% to 15%. Today in the US, the baseline NNRTA resistance is almost around 12 to 15%. And in UK, it's around 10%. And in some countries in Africa, it has touched 10. And in Asia, it has been hovering between 3 to 6%. So I think, if our resistance baseline goes up, efavirenz again will not be a good, perfect choice for starting treatment. We need other alternative drugs. Following all this evidence, the new WHO 2016 guidelines also recommend 2 other alternate options. One is reducing this efavirenz 600, which causes suicidality and various CNS toxicities, to efavirenz 400, and another one is introduction of new drugs, that is dolutegravir, which you heard a little earlier. And again, going into what is this evidence of reducing this dosage. So this is a trial called ENCORE study. So what this trial did is, they compared 2 groups of patients. One received on standard 600 milligram efavirenz, and another one, test arm, received 400 milligrams. So this is a very large study on 600 patients, 300 in each arm. X-axis is the duration in weeks, and Y-axis is proportion of patients who have suppressed viral load. And here, if you see the red color graph, it is on patients who are on efavirenz 600, and the white color one is efavirenz 400. If you look into this virological suppression, both are same, both 400 and 600, irrespective of the body weight. Here, they didn't look into the BMI, it's been same. But very importantly, looking into the comorbidities of efavirenz on suicidal tendency and CNS toxicities, if you look into this efavirenz 400 arm, where there is dramatic reduction of efavirenz-related adverse events as compared to 600 milligram. So again, by implementing the new WHO 2016 guideline, by reducing 600 to 400, you'll be able to reduce a major comorbidity of efavirenz-related adverse events. They're not looked into the suicidality, but other various CNS toxicities which we see in our patients. As a result, they tend to disrupt the medications. But if you go into this newer drug of dolutegravir, majorly what we will see is again a trial called single trial, which compared between dolutegravir versus efavirenz. Again, if you look into the x-axis is the duration of patients on treatment, and y-axis is proportion of patients who have got suppressed viral load. The green curve is patients who are on efavirenz, and the white one is on patients on dolutegravir. Again, if you look into that, higher rate of virological suppression with the newer drug, dolutegravir. And also again, if you look into this, I said this morning, the suppression occurs much earlier, even before than efavirenz. This will have a tremendous effect in terms of prevention, and also you heard a lot of talks on reservoirs setting up. Again, if you start treatment early at a higher CD4 soon after diagnosis, put them on dolutegravir, the virological suppression will be much earlier, so thereby we can even prevent the, even the formation of certain reservoirs, thereby even one day if there is a cure, even the strategy will be much, better. So again, implementing the new 2016 guideline will also step the phase for the future cure and eradication strategies. Again, the study also showed that, as compared to efavirenz, there is almost no CNS toxicities. It's been very clear. I think, this will be a huge impact. Now, coming to the viral load, I will not spend much time on that. Just again, various speakers this morning talked about that. So, new WHO guideline very clearly states that routine viral load monitoring is mandatory, and that's a preferred mode of choice. If you're not going to do this, we all know that, you'll end up in patients either sick, or they have already failed, they have accumulated mutation. Again, you heard this morning from various resistant lectures, thereby it can jeopardize future regimens. So today in the WHO 2016 guidelines, also recommend the second line and third line. This again, you'll be able to use this in a public health approach only if you got viral load monitoring. If you don't have a viral load monitoring, we and others have shown in the past that if you don't do viral load monitoring after first line failure, the accumulated NRTA mutation can jeopardize future second generation NRTAs, which are preserved for third line. And if you're not doing viral load monitoring following PI failures, and accumulated PI mutations can also jeopardize darunavir efficacy for third line. So there will end up in having no drugs. So again, the impact is if you implement viral load monitoring as part of the WHO 2016 guideline, we'll have a better second line and third line and better impact on the patient's productivity. Right. So I just wanted to show this data, which has been analyzed from a very large data set called a Treat Asia data set. This has been data being collected from 7 countries, from different clinics of almost around 16,000 patients. What we looked into that is, we looked into the patients who received care from different durations. We looked at the patients who have been started on ART between 2003 to 2005. We looked into the survival probability. We found it's almost 92%, 4-year survival probability. There is a guidelines we started treatment when the CD4 is less than 200. But when you look into the patients who initiated treatment between 2006 to 2009, where the patients have started treatment at a little at a higher CD4, survival probability increased, and 2010 to 2013, where they used 350 threshold, also they used tenofovir, where the survival probability much more increased. Now we are also looking at the 2013 guideline, and also I personally feel when we do this analysis, if we implement 2016, the survival probability might even touch 100%. That again, based on the better drugs we are using, better monitoring, and better switching, and the availability of all those. So implementing newer guidelines will have a better survival probability in our patient cohorts. And just before I conclude my talk, I'd like to say that this is something what is being done by UNAIDS and other organizations. What will be the major global impact if every countries start implementing the WHO 2016 guideline? We'll about 21 million AIDS-related deaths, and also will be able to prevent 21 million new HIV infection by 2030. If India is not going to join this war, so we'll not be able to achieve this. I think it's right time that we should start implementing in our region so that we'll be in pace with the global scenario. So you may ask a question on cost. Again, I showed this morning. So our group, in collaboration with the Harvard group, have already shown that starting treatment at a higher CD4 is being cost-effective and cost-saving both in India and South Africa and even in various other countries. So this is a data being published a couple of days back. Many of you now have seen this. So this is a group of investigators in collaboration with a group in UK. What they have done is they have used a WHO 2016 guideline indicators and also the data from START study, and they have done the cost-effective analysis in Nigeria, South Africa, Uganda, and India based on the cost per daily averted. What these investigators have shown is if you implement the WHO 2016 guidelines, including starting treatment early, as well as putting on the newer drugs, there will be immediate cost effectiveness will be seen, and as well as likely even cost saving over a period of time. This very clearly shows that it's not there's no point in delaying implementing this. By implementing this, you'll have a huge impact on preventing transmission, preventing morbidity, and in future in science, even setting the phase for future cure and eradication strategies, and as well as will be even cost effective. Will these newer ARVs will be cost effective? Clinton Foundation has already done and published showing that reducing the dosage from 600 to 400 milligram will be cost effective, and also will have reduced the side effects. And also our group in collaboration with the Harvard have very recently done this work. I don't have the data to present, we just submitted to CROI, and what we have shown is implementing dolutegravir, even in India, even I do not know the cost, but I heard the cost will be marginally higher than efavirenz. But if you look into all those failures and prevention effect and as well as adverse events put into the model, will be cost effective on a long run. So even introduction of the new ARVs will have a huge impact even reducing this cost. With this, I'll be ending my talk and happy to take questions later. Thank you very much.